The prescription drug overdose problem in North Carolina came to my attention initially in 2001 and 2002 while I was serving as the state's injury epidemiologist, because it is standard procedure simply to run the numbers every year. So, how many people are dying or being hospitalized for car crashes or homicides or dog bites or poisonings. And I was simply running the numbers to see what was happening. And almost all of the standard injuries that we follow in the state, the number of people dying from these injuries had either flattened out or were actually decreasing, except for poisonings. And I looked at these numbers, and my understanding of a poisoning, and it was consistent with what most people think. These are little kitties crawling under the kitchen sink, drinking Drano or gasoline in the garage. And we looked at these data very quickly and saw that almost all of them were related to medications. So, being relatively new in the injury field of epidemiology, I called CDC and said, I need help. Please send me your cadre of EIS officers, the Epidemiologic Intelligence Service folks who come when there is an outbreak of some kind. This was the first time that anyone had ever called CDC for poisonings. So these folks came. We spent a lovely 6 weeks working at the Office of the Chief Medical Examiner, going through well over 1,000 medical examiner records over a 5-year period. And lo and behold, what we found was, yes, the change we had seen in the number of poisoning deaths was not due to the change in the coding systems. We'd gone from ICD-9 to 10, but these were in fact real. Almost all of the deaths were due to medications, and a good 2/3 of the medications were opioids or other illicit drugs that were being used on the street. But almost all of them were prescription medications, which we hadn't expected at all. So having seen this and seen that in this group, methadone was one drug that caused 1/3 of the fatal overdoses. So we wrote a little paper, put it in the New England Journal of Medicine, and this created a stir within the state, within the nation. We went to Washington and testified that, yes, indeed, there were more people dying from methadone than we had expected, but these deaths from methadone were not due to people who were in opioid treatment programs, but were receiving methadone for pain management. So this is where things began. I went back to the state, was able to construct a very large task force of people from all over the state with different areas of interest in overdose prevention to try to get them to come up with a series of recommendations. We did that, and several of the recommendations were to work within communities to build the interest at the community level to deal with the opioid overdose problems. So we did that. After I retired in 2007, I immediately started working in Wilkes County because I had already been invited there by the health director in the county to come and talk to them and raise the awareness of overdoses in the community. And sometime in 2007, early 2008, working with Fred Brayson and Nabdas Gupta and Dr. Sue Albert, we began putting together Project Lazarus because we knew that we had gone from just a casual awareness in the community to a heightened awareness because in 1 week there had been 3 deaths from an opioid overdose. And what we began to understand is not only do you need the large number of statistics from the state, but you have to have something in the community to speak to the hearts of everyone who lives there. So we began looking at building a program that would resonate within the community and give the community a whole set of options that they could use. Hence, Project Lazarus was developed because we knew not only did we have to change the behaviors of the people who were taking medication, the families and the cultural norms in the community, we had to change the way medical care was practiced in the prescribing of opioids, in the emergency rooms. We had to change the way law enforcement worked, and we had to put into practice something that would immediately save lives. Hence, what we originally called a safety net, because the concept of harm reduction was a bad word and you couldn't use that. But we had a harm reduction component, which said that we absolutely had to make sure that every family of someone who was misusing or abusing an opioid, whether it was a prescription opioid or an opioid on the street like heroin, or a prescription opioid that was being used for recreational purposes, all of these friends and families of the people who were misusing and abusing had the training and the medication to reverse the opioid. One of the things that we had found in this big medical examiner study we did was that 2/3 of the people who died from an opioid overdose had been seen by a family member or a friend several hours before the death occurred, and nobody knew or wanted to do anything. They were afraid to call 911, or they didn't know they should call 911. They had no clue what to do, and the response was, well, they've gorked out on the drugs before, we'll let them sleep it off. And these people didn't wake up. So Project Lazarus was born out of my initial entrees into Wilkes County saying, you all have a problem. One of the things I learned as a worker for state public health is the one thing you never do is waltz into the community and say, you have a problem, I'm from the government, and I'm going to fix it. That doesn't work. So we had to build a project, an intervention strategy that used the community as well as provided them with options and strategies to prevent overdose deaths, even if it meant 2 minutes before they could have died or 2 years.